tissue, okay? It has to be fixed to the bone. It's gonna be nothing on removable or movable tissue, so just think about that. What do we usually find on movable tissue? Abscess ulcers, right? So any of our herpetic lesions are usually, now this is not 100%, but are primarily only on, because it's not to say that abscess ulcers are only gonna be on movable tissue. It's just a telltale sign that this is what we can kind of, make a differential diagnosis of where it's located. Because you're always gonna have that one patient. You're gonna be like, but it can't be there. But it is. All right, so what I was talking about before was the herpetic whitlow, which is going to be on the fingers. So that's why you always wanna make sure that your gloves are intact when you are seeing patients with any type of herpetic lesions. Here, we dismiss. In the real world, you won't. But can someone explain why it's so important to try to think about dismissing patients or patients not coming in when they do have, cold sores or herpetic lesions? Because not only with touching, but what else? It can spread to other people.
And
it can spread to other
them.
areas. Aerosols as well. So, this is a virus. So if you're in there and you're blowing that air water or they're coughing or you're using depending on where it's located, those aerosols, if you're not covered properly, can also get into your system and then can infect you as well, or at least get the virus in you. So, that's why it's very important that it's just not about touching it or about touching the patient and you're touching other areas, which is what I get concerned about, because if I see a patient there, I'm going to manipulate the tissue and everywhere else so I can actually get in there and clean what I need to clean. But if I'm touching, I have to touch this, and I'm not going to change my gloves, and then I'm going to touch somewhere over here. We're spreading it. So I know the patient doesn't understand, and then the dentist thinks, okay, well, I'm not going to turn away a patient, just be careful, but then, why would you want to run that risk? And then also in the eyes. So you can get it, which can also cause blindness. There's also one that can actually be that it's not going to show clinically, I should say, on the eye, what this picture will, and it's like in the actual nerves of the eye, of the ocular nerve, which can, over time, as the outbreaks, you'll never actually see it clinically or see a clinical appearance of it, but over time can lead to blindness as well. All right, so we know about topical antiviral. We know about Abreva, which can be a topical one that is over the counter. Can anyone tell me about a systemic drug that you can take? You guys know about systemic.
I don't have TV, so I don't see any commercials.
I thought you said I don't have TB. I'm like, what does that have to do with that? No one wants to know about your tuberculosis. So Valtrex. Valtrex can be something that can be taken, systemically, that can help reduce the reoccurrence or the duration.
Do you take that all the time or just when you have a flare-up?
Usually when you have a flare-up. I don't think you should be on a daily regimen of Valtrex.
Once it shows up, so it's not going to prevent them from showing.
Well, right. So it's usually when you start getting those first symptoms. So when it's in the prodromal stage of the disease or the virus, and you're starting to get like the itchiness or you're feeling some kind of burning sensation, and that's when you go ahead and you take it. Then you may not have the actual lesion show up, or if it does, it may not last as long.
Gotcha.
Yeah, I don't think I've ever heard of someone having just a standard supply of just Valtrex.
Well, some people are worse. I didn't know if they
and
had
that's very
reoccurring.
True. And some people do get it reoccurring, of course. But then Valtrex is also, which is the stigma, because when you think of Valtrex, you think of, HSV2 and thinking of, just genital herpes, but it can work for, HSV1 as well, because it's all pretty much the same virus. It's just pretty much where it manifests at.
So if they keep recurring because of their immune system is suppressed, could they take something that
they
would
could take
help?
it, but I really wouldn't think they would take it every day. I don't know the studies on that, but I know because usually you're going to take it for a duration, and then usually, hopefully, then it will suppress enough to get you through, and then once you have another reoccurrence. But I would hope it's not reoccurrence after reoccurrence, like one heals, and then, but you never know.
People that are stressed or immune compromised or
right. Or who have an immunodeficiency disease, right? It can manifest better or more prevalent than others. So,
do we need to know those two drugs, Abreva
and Valtrex? You'll need to know when you get into pharmacology. You don't need to know it for this one. All right, so we already kind of talked about that a little bit. So we know that it's an antiviral drug. We're going to take it at our first prodromal stages of the virus, meaning its first initial stages once we start feeling any type of symptoms, and it can actually lessen the duration of it or actually not show any type of signs. This is our herpetic whitlow.
Oh gosh.
And this is
I
the one
can't
over the
unsee
eye.
that.
So this is what I'm saying, that, you know, when you're in the mouth and you're touching other areas, you know, what it can lead to, or aerosols, you know. There are a lot of offices out there who do not make their patients wear protective eyewear when you're cleaning. So that's kind of scary because, you know, there are aerosols everywhere. So it's not just to protect, you know, us, it's protect the patient as well.
Did that start like inside their eye? Or
This
is
one
that
is on the
solely
outside.
on the outside?
That's on the outside. Usually if you're gonna find it on the inside, on the ocular nerve, you're not gonna see this type of, you know,
Is that
manifestation.
something like they would have to have like a little scratch or something on the outside to like let it get in there? Or it just,
Well, it depends if they're touching here and then they're rubbing their eyes, or if they have a herpetic whitlow on there and they're rubbing their
Oh
eye.
gosh.
It's all, you're just transmission it to whatever other part of the body. That's why it's extremely contagious when we're talking about, you know, HSV.
That is their eyelid just closed, right?
Yes.
Okay.
I mean, you know, it could be a bad case of pink eye too, but I would not.
Could they open that?
I mean, look at the, you know, you have the
Painful.
crustacean all around here, so probably not.
Like it
So
doesn't look.
Does that's like a really bad picture.
Yeah.
Okay.
Yeah. This is like the worst of the worst that you would see.
Okay.
You wouldn't see someone coming in for your 8 o'clock appointment. I would hope not. So that's just a normal one, and then all right, so we kind of already touched over Brucellus zoster virus, which is the chickenpox. We'll kind of go through this a little bit more. Your book does a really good job explaining it, but just some telltale things that you really just need to take away from this is kind of what we already discussed. So the initial infection, or what we're going to have, is actually the chickenpox. From there, the virus remains latent in the body, which then can reoccur as shingles. We have the vaccination for chickenpox, which can prevent, but there's no guarantee, and I said it will, but there's actually, it can, because there's no guarantee that anything will prevent shingles in the future, as long as it's in your body. And you do have a shingles vaccination for it, but even the shingles vaccination doesn't prevent you from getting shingles, kind of like the flu vaccination, kind of like the chickenpox vaccination. So you have all these vaccines which are helpful, but there's no guarantee that you will not get it. All right, and I just kind of briefly touched on measles and mumps, only because of what's kind of going on now, and I think, you know, with vaccinations and, you know, kids not really getting vaccinated against the measles and mumps, or the measles and mumps. There is no "the" in front of it. But in knowing for the measles, we have the Koplik spots, which are just these red, petechiae, kind of aromatic areas that are kind of everywhere that you'll see. And you'll see in the center of it that it's more necrotic. That's letting you know that's just, you know, another sign of oral manifestation of measles. And then mumps, kind of knowing, oh, that's the picture of it. So right there in the center is where it's necrotic. And you can kind of see that around. Which I hope someone wouldn't bring their child to get cleanings with measles. And then mumps, kind of the same thing, where it can actually, if not treated, or if you're not vaccinated against it, which is another vaccine that can help, and I don't really know, I mean, everyone has their beliefs, so if you're anti-vaccination or you're for vaccination, that's completely up to you, but, you know, the only thing about that is when you have sick kids or kids who do have cancer who aren't able to go to school, because you have some kids who aren't vaccinated and they are immunocompromised, so they're missing out because children aren't vaccinated. And then you're having these exacerbated hospital bills because a vaccination could have helped, but, you know, to each their own. All right, so chickenpox. we already know about this. I mean, there's really not a lot to talk about. You know, it's pretty much the same thing where you're going to have, you know, this pruritus rash is going to form. You're going to have the vesicles. You're going to have, you know, flu-like symptoms, so the malaise, the sore throat, and then you're just going to kind of wait until it's kind of, your body heals on itself, and it kind of makes the virus then latent. All right, so shingles, which is going to be another thing of the varicella zoster virus. So what this is pretty much, you can see it, all these kind of run together with the same immunocompromised or elderly or patients who just can't fight off it being latent in their system anymore. So usually what happens is that we have it as we get older. We know our immune system, you know, I'm just making up words here. Our immune system becomes, you know, more debilitated, and so we're more prone to different diseases and different things that have remained latent over time. Or, you know, it can be a sign of, depending upon the age, if there is someone really young, I mean, once again, you can't make that general consensus as someone who is in high school or in their 20s or 30s has HIV or AIDS because they have shingles. It depends on what's going on in their life. You know, it's very much can be stress induced as well. All right, this just kind of goes over it. One takeaway here is the neuralgia that can take several months, and what that pretty much is just that, you know, that pins and needle kind of nerve, not really nerve damage, but just that nerve feeling that when things are kind of, I guess it's kind of like nerve pain, that can take longer. You'll kind of feel that there's still something there. So even though, you know, the virus is kind of taken care of and it's gone, you'll still have those kind of remnant issues leading up from the nerve pain. All right, so it's usually unilateral, and mainly what you're going to have it is going to come from the chest and the back, from our nerves and our spinal cord. This one can also affect the trigeminal nerve, which is why we can have it on the face as well, which I think I just said it here. So yeah. All right, so treatment, once again, it's just going to be the palliative care, vaccination for 60 and above, and then pretty much you can try to take an antiviral, but it's going to have to just like chickenpox, you're going to have to let it just kind of work its way out. Sometimes a lot of times this will take longer than chickenpox to actually diminish. That's it on that side.
Ooh.
And you can see it right there where it's unilateral.
Ooh, that's crazy.
All right, Epstein-Barr. Tell me about it. What is it? What?
I said it's from the devil, I'm sorry. I've been seeing all kinds of stuff, how this virus actually plays into a lot of issues later. Like a lot of autoimmune diseases, it's being connected to it.
Really? I didn't know that. All right, so the main thing with this is going to be mononucleosis. So, which we all know what mono is, you know, the kissing virus that you can have. A lot of this can affect the nasopharyngeal and the oral pharyngeal as well. So we want to make sure that these viruses, or this virus in particular, is kind of, you know, at bay. And then hairy leukoplakia. So what is hairy leukoplakia? And what patients are usually presented with this, or present with this? No, that's leukopenia. That's hairy tongue. So AIDS patients, pretty much. You guys were close. All right. Right here, almost. I'll give you the benefit of the doubt.
We tried.
All right, so we know between you know, the kissing. Also, this is with sharing like water bottles or anything. So it's just with saliva, anything like that. So any type of, so it has the bad rub of kissing, but you know, I've seen the majority of a football team get mono because they all drink
That water bottle.
Yeah. And then especially they put their lips on it. I'm like, why would you do that?
You
Just so.
Squeeze.
Good Lord. All right. So with this one, we know that we're going to first start off with these red inflamed kind of petechiae areas. Then they fade to these brown spots. And then from there, we can kind of go into more of like the flu-like symptoms of the lymphadenopathy, the malaise, the sore throat. And then the fatigue. The fatigue is gonna be the main thing you're gonna see with mono because there's just not enough energy there because the body is really trying to fight off the infection. All right, so symptoms will disappear in about 4 to 6 weeks. Patient may feel tired and prolonged over time, which is we already know about the fatigue, and then we already talked about the pharyngeal tissues and tonsillitis that will also be inflamed as well that we can notice with this. These are just some oral manifestations of that.
Do you always get oral manifestations with that?
Usually, I mean, you may, and it's kind of like any type of virus, especially if you're looking at the tonsils. You know, you'll maybe notice some, you know, white spots or just the inflammation. Because remember, with bacteria, we have the telltale sign with bacteria are the white spots, and then with viruses, it's just the redness and inflammation that we're noticing. But you may not always get that.
Yeah, because my sister had it at one point, and she never had like any lesions, but like her tonsils were like extremely swollen and like really red. And I think at one point they were actually like pretty white.
Really.
Mm-hmm.
See, you really don't know. But then, you know, if you look at that and you're seeing how inflamed and red they are, you're going to think automatically that it's viral. But then with the white spots, you're also going to think, okay, well, it could be bacterial as well.
Yeah.
Which is why you just get the test done.
Which is so horrible.
Could it be both?
Yeah.
I mean, it could be viral and bacterial at
No.
the same time.
You can't have
No,
viral.
I mean like they can have a bacterial infection and a viral infection at the same time.
At the same place, like orient.
Yeah, like in the
No.
tonsils. Can you not?
No, I mean, because whether you're going to have a viral systemic infection or it's going to be bacterial. I mean, not to say that you can't have a bacterial infection if you're fighting off a bacterial infection somewhere else, and then you can have mono, which is going to be viral. So you could have those, but like you can't, like in the tonsils, it can't be bacterial
Both
and
at the same
viral at
time.
the same time because you got to take some kind of medication. And remember, you know, bacterial, you're going to have a different type of, you know, narrow, you know, you either take a broad spectrum or a narrow, but for your viruses, there's not really too much you can do for a viral infection, which is the bad thing about that. It's just wait it out so your body can heal itself. So you don't want to give an antibiotic to a patient who has a viral infection because it's not going to do anything except build a resistance for the patient. All right, so hairy leukoplakia, we're going to see those corrugated lines, and we're going to see it on the lateral borders of the tongue. This is going to be pretty much in any type of immune suppressed patient or HIV patient or AIDS patient. Associated with the Epstein-Barr, and then we already talked about HIV again. And that's it right there. Coxsackie virus. So weird to say that. All right, so we know about this, and I really want you just to kind of look in your book for this, but, and there's not a lot you really need to take away from this. I mean, hand, foot, and mouth, you know, they're all gonna have the same types of manifestations. You're gonna have the blisters, you know, what is it, something I wanted to point out with, for Congena. Give me 1 second. No, I guess I'm lying. No, because they all have pretty much the same symptoms. They're going to have those flu-like kind of symptoms. So the lethargy, the sore throat, the fever. Just kind of know what's what. You're not going to have a lot on this, and then boards doesn't really even talk about this a lot. But it's just something that, you know, it'd be good to know. So if you see any type of oral manifestations, you can look at
What
them.
did you just say
With what?
for us to know about this? I'm sorry.
You really don't need to know anything
Oh,
about this. Yeah.
There's one other PowerPoint that we have for this test where it says like just read this in the book. Is that gonna be test material at all?
Mm-mm.
Okay.
And usually with that, and you'll get that also when we go later into the chapters, a lot of this you just kind of have to, I want you just to kind of be familiar with it, but not to really be tested on it because, and like I said, we can't really test towards the boards because we don't know what they're gonna pull out of it. But, you know, it hasn't been something that's ever been brought up there. All right, we're gonna take like a 5-minute break really quick, and then we're gonna power through this, and I think we're gonna be